Alrighty, everyone, we'll go ahead and get started. Who's ready to learn about sleep apnea? Woo! I'm Leah. I work at VCU Health with Dr. Ryan Nord, one of the sleep surgeons, and we're going to be talking about sleep apnea. We're going to talk about what it is, how we treat it, what are the risks of not treating it, and then lastly, what are some other options other than CPAP, mainly the Inspire device. First, though, I want to get a quick raise of hands. Who here has been affected by somebody snoring and hasn't gotten a good night's sleep because someone is snoring really loudly? Me too. So sleep apnea is a very prevalent disease that a lot of people aren't aware of, so we're going to talk about that a little bit more. So like I said, I'm a nurse with Dr. Ryan Nord at VCU Health. Dr. Nord is our sleep surgeon. We work in the ENT department at VCU. Dr. Nord has been working at VCU in this role for about 10 years, and I've been a nurse for 6 years, and we've been working together for about 1 year. But together we make the sleep surgery team. I want to go ahead and get right into it. What is sleep apnea? So a lot of people hear that and they think, okay, it's snoring, something's going on when I'm sleeping. If you take the two words and you think apnea, apnea means without breath or not able to breathe, and then sleep, so sleeping and not breathing well. So essentially, sleep apnea occurs when there's some kind of anatomical structure going on in your airway, causing a collapse on your airway, making it harder to breathe. So either that's your tongue or your soft palate relaxing while you're sleeping. If you think of people when they're asleep and they're laying on their back, their tongue is falling back on their airway, it can be that. More than 2 million Americans are diagnosed with sleep apnea every year, so it is a very prevalent disease. Symptoms of sleep apnea. You heard me talk about snoring being the main one. So a lot of patients will describe snoring as their partner, it sounds like a chainsaw. I've had some people say it sounds like there's a chainsaw or a weed whacker in the room. Or some people might even hear their spouse stop breathing at night. That's a big one too. The stopping breathing, you may wake yourself up from not breathing at night. Another symptom of it is excessive daytime sleepiness, as you see this little kid here asleep at the airport. Excessive daytime sleepiness is something we see a lot because if you think about it, you're not getting an adequate night's sleep because you're not breathing well while you're sleeping, so that results in the excessive daytime sleepiness. Poor concentration is another one as well. If you think about it, if you don't get a good night's sleep before, you only get like 2 hours of sleep, you're not going to be at your best the next day, so that is also a symptom that we see very frequently. Morning headaches is one as well. If you have unexplainable morning headaches in the morning and you have maybe some of these other symptoms, maybe time to go get checked out for sleep apnea. So how is sleep apnea diagnosed? Sleep apnea is diagnosed through a sleep test, which some of you may have had. You may have done one in the lab, you may have done one at home. How we test for it and how we know if you have sleep apnea is we grade things based on hypopneas and apneas, which is basically a fancy word for you not breathing very well at night. So the apnea refers to a complete cessation of breathing. A hypopnea is you're trying to take a breath in and maybe there's some kind of obstruction in the way and you're not able to get an adequate inhale in. So those are kind of counted throughout the night when you're going through a sleep test, and then those are graded for, okay, you had 10 an hour, you had 11 an hour, you had 200 an hour, they're all graded that way. So the different levels of sleep apnea are mild, moderate, and severe. You can see below here, severe is more than 30 events an hour, mild is 15 to 30, moderate is 15 to 30, and mild is 5 to 15. And then of course, anything below 5, congratulations, you don't have sleep apnea. So another thing a lot of patients ask me is when they talk about getting treated with sleep apnea or wanting to get tested, no one wants to go sleep in a lab. No one wants to go overnight, not in their own space, and have someone watching them sleep at night. So home sleep apnea tests exist. They're something that are becoming a lot more prevalent. They have a lot of new systems nowadays. Your primary care doctor could prescribe something like this for you. And it can look as simple as just a watch. Like you see this patient has, he has a little watch on his hand and then a pulse ox monitor on his finger. So sleep apnea tests can just be this simple. They're easy, they're inexpensive, and they're accurate, just as accurate typically as an in-lab test. So what are the risks of untreated sleep apnea? So specifically, this is referring to severe sleep apnea, which is above the 30 events an hour. So that can make people about 4 times more likely to have a heart attack or a stroke. So a lot of patients that we see come in our office ask, why do I need to treat my sleep apnea? Yeah, I snore at night, but it's not that bad, or yeah, I'm sleepy, but I can get through it. Why should I treat my sleep apnea? Well, it's very important for your heart health. That wear over time of not treating your sleep apnea can lead to things like heart attack, stroke, even death. They can also cause heart arrhythmias. We have a lot of patients that we see that have AFib. And a lot of patients will ask us, why do I have AFib? I was perfectly healthy before this, now I've got these heart arrhythmias, and that can be caused by untreated sleep apnea. If you're in the mild category, you are not at risk for these things. So again, sleep apnea is more common than you think. I like to bring up this statistic. It's about 7 to 10% of the population, just under diabetes. If you think about how many people you know with diabetes is about 11% of its prevalence in the United States, and then sleep apnea is about 7 to 10%, so it's right under diabetes. So very common. This is a map showing its prevalence across the world. The blue marks are where we tend to see the higher concentration of sleep apnea. So about 1 billion people in the entire world have sleep apnea. But unfortunately, about 80 to 90% of the people who have sleep apnea don't get diagnosed. This is the map prevalence for the United States specifically. The dark red is the higher prevalence of sleep apnea, and then the lighter colors are less prevalent. So unfortunately, with our state in Virginia, sleep apnea is very common. So now we're going to talk a little bit more about the treatments for sleep apnea, specifically starting with CPAP. CPAP is the gold standard. Has everybody heard of CPAP? Maybe you use CPAP, you have a friend who uses CPAP, yep. So CPAP is the gold standard. It's a non-invasive, cost-effective option. CPAP stands for continuous positive airway pressure. It works by blowing air down into your airway at night, so if there is an obstruction, the air is able to bypass that, so you're still able to get an adequate night's sleep. It is a great option. It's very effective for people who can tolerate it, but a lot of people may not be able to tolerate it. So about 46% of patients who are prescribed CPAP are not able to tolerate it, whether they just forget to put it on in the middle of the night, whether they have claustrophobia, whether it falls off in the middle of the night, but about 46% of people, CPAP isn't a good option for them. So what do we do when CPAP isn't a good option for you? That's where me and Dr. Nord come in. So we specifically work with the last 2 options on the screen here, but I do want to touch on some of the other ones as well. So there's an oral appliance. If CPAP isn't working well for you, an oral appliance is basically an upper and lower mouth guard that pulls your lower jaw forward, essentially widening your airway so you can breathe normally. This option is good for people with mild sleep apnea. It's less effective the more severe you are, and more into the severe category, but again, still a great option for people with mild sleep apnea. There are anatomy-altering surgeries that we can do where we rearrange some of the tissue in the throat to widen the airway. That can be a good option. And then lastly, we're going to talk most about Inspire, which is the medical device that acts as a neurostimulator to open your airway naturally so you can take a breath in. And it's a discrete option. All you can see here, you have a little remote. Hopefully when you came in, this is a little stress ball. So I also want to talk about why sleep apnea occurs and what is going on in the airway. So we know that there's the home sleep test or the in-lab sleep test that'll tell you that you have sleep apnea, mild, moderate, severe, but what is going on in my body that's causing that? So there are different structures in the airway that can cause the obstruction. For most people, you can see this little red circle here, it's the base of their tongue. So your tongue goes all the way down into the back of your throat. So for most people, it's the base of the tongue falling back. For some people, it's your epiglottis, which is your little food flap so you don't swallow food down the wrong way. It can be the sides of your throat closing in. It can be your soft palate. It can be a lot of different things. Well then, how do you know what you have? So there's a procedure that Dr. Nord and I do at VCU Health called a DICE exam, or a drug-induced sleep endoscopy. It's an endoscopy procedure where we would bring you back into the operating room. This is, of course, after you've tried CPAP, maybe it's not working for you, and you're wanting to look into other options. We would do this exam, we bring you back into the operating room, we give you medicine to fall asleep, and then once you're asleep and snoring, we look in your airway and see what's going on. What is the issue? Is it your tongue falling back? Is it the sides of your throat closing in? And then this would, of course, help us find which surgical option is going to treat your sleep apnea the best, because no shoe fits all with sleep surgery. So there are 3 different surgeries that I want to talk about a little bit more. We're going to talk about nasal surgery and how that can help you use CPAP better. We're going to talk a little bit about soft tissue surgery, and then mainly Inspire. So treating nasal obstructions can be really helpful if the reason you can't use CPAP is because you have some type of blockage in your nose. So we see a lot of patients who maybe tried the nasal pillows, or they're trying CPAP, but they have so much pressure in their nose, or they have allergies, they're not able to breathe very well that they can't, and that's the reason they can't use CPAP. So there are different surgeries that Dr. Nord can do to widen your nasal passages, essentially, or to fix any crookedness. You can see in this first picture here, this is looking into the nostrils. The first picture is showing a septal deviation, so the piece of tissue that divides your right and left nostril, that can be crooked, causing an obstruction. And then the second picture here is a big polyp in someone's nose. So all of these can be things that inhibit people from using CPAP. I would like to clarify too, we get a lot of questions asking, will this improve my sleep apnea? If we treat my nose, is that gonna make my sleep apnea better? The short answer is no, because sleep apnea is caused by an issue in your throat rather than your nose, but treating your nose can help you use CPAP, which then, of course, the CPAP is treating your sleep apnea. There's also soft tissue surgeries that Dr. Nord can do. Say if you have your DICE exam and it's showing that it's the sides of your throat closing in or a smaller airway, there are different surgeries that Dr. Nord could do to widen your throat. Where I have it circled right here is mainly the tissue that he would be operating on. That can bring anybody from 42 events per hour to about 6 events per hour, so it can be very effective for patients. Lastly, I'm going to talk about the Inspire device. I have Darlene here as well. She's one of the members of our sleep surgery team in the back. She'll be here to answer questions later. Inspire, I like to describe this as a pacemaker for your breathing. It is a surgery. It's a surgery done with 2 incisions, one in the neck, one in the chest, relatively small incisions, about 3 centimeters long. And again, this acts as a pacemaker for your breathing. It's been around since about 2014. A lot of patients, you may have seen commercials about it. I feel like the commercials have been popping up very recently, but Inspire has been around for a long time, and it has been FDA approved for a little over 10 years now. So this is a chart kind of showing Inspire being around. You can see it was FDA approved in 2014, where the second arrow is in 2017. That is how long Dr. Nord has been doing the Inspire procedure here at VCU. And we've just reached about 100,000 patients treated with Inspire. This is what the implant looks like. This kind of goes over the different models that we've had since the Inspire device has come out. There have been 3 different models. We've now graduated from 3 incisions with 3 separate hardware components now to just 2 incisions and 2 hardware components. I'm going to talk a little bit more about the hardware as well. The one that you can see in the chest is the battery. It powers the device for 10 years. When it needs to be replaced, it's as simple, you reopen the incision, you put a new battery in. It is an outpatient procedure. It takes about an hour long. Patients go home that day. Again, 2 incisions, it's hidden underneath your skin. A lot of patients will ask, is this something I'm gonna be able to see? Is it gonna be right on top of the skin? No, it's generally not noticed by patients unless you push down on it and go to feel for it. So how it works to alleviate the obstruction on your airway is it gently sends a pulse to your tongue to pull it forward off of the airway. So you can see here there's a little cuff that wraps around the nerve that controls your tongue, which allows us to stick our tongue out of our mouth. So it sends a little pulse in the middle of the night while you're asleep. You try to take a breath in, stimulates your tongue, pulls it off the airway so you can get in a breath naturally. And then when you exhale, it turns off, and then your tongue goes back to relaxing. So again, allowing you to naturally take a breath in. Here's a video here of one of our patients. You can see this is what the device actually looks like working. So a lot of people think it's gonna be like a lizard. A lot of people use that animal, and they say it's gonna be like a lizard. My tongue's gonna be flying out of my mouth in the middle of the night. My spouse is gonna make fun of me. This is what it looks like. It's just a gentle pulse towards the edge of your mouth. And most patients can sleep through this, no problem. That's the goal, right? So we want to give you a good night's sleep. So if it's waking you up in the middle of the night, then we're not doing our job, but for most patients, we can get them to the point where it's easy. They can sleep through it, no problem. It's very discreet. It's just a gentle pulse. So I'm going to show this as well. This is hopefully nobody's squeamish here. This is looking down at the airway from the nose down to the top of the throat down. So on the left, you'll see that's no stimulation, so meaning the Inspire device is off. You can see how closed the airway is. You can't see any black space in there for room for air to get in. And then on the right, you can see that's with the Inspire device on, and that's how it opens up the airway, so you can naturally get a breath in. So going in a little bit more about what to expect after surgery. So again, it is outpatient, so you'd be discharged the same day. Most patients complain of just mild incisional pain. Otherwise, you're good to return to normal activity after a few days. After 1 month of having the procedure, we let everything heal over, take time to heal, and then we turn the device on, and then you would go home using it with this little remote here. So a lot of questions I get asked from patients is it on throughout the day? No, it's not on when you're awake. You control when it gets turned on. So whenever you go to sleep at night, you would just press the green button, put it up to your implant. It would send a little test to you to turn on maybe in 30 minutes, 40 minutes, giving you enough time to fall asleep. And then once you're falling asleep, this will kick in. And then you take a breath in, it stimulates your tongue forward, you exhale, and it turns off. So it would do that for 8 hours until you turn it off. Lastly, after about 3 months of having the procedure, you would get a sleep study, because we obviously want to see, is it doing what it's supposed to, and is it treating your sleep apnea? So for most patients, around the 3-month mark is when we would get this. You would have a sleep study before you have the Inspire procedure. So whether you're severe or moderate, and then after you have the Inspire procedure, we would get a sleep study. So this is a clinical trial that was done over a 5-year period that I like to show. It was the STAR trial. The chart on the left is showing people's events per hour, or the AHI, the apnea-hypopnea index, which is just basically just showing how severe someone's sleep apnea is. So again, on the left, you can see for our average patient, their number was around 30. So in the severe category, that was before they had the Inspire device. And then following these patients for 5 years after the Inspire device, most patients came down to about 6 events per hour, which then puts them into the mild range, taking away that risk for heart attack and stroke and things like that. The chart on the right is the sleepiness scale. So we get all these questionnaires prior to patients having the Inspire procedure, which this basically says, do you feel likely you're gonna fall asleep if you're reading a book, fall asleep while watching TV, different questions like that. So patients were reporting feeling very sleepy prior to the Inspire procedure, and then after the Inspire procedure, less sleepy. So it was doing its job. This is another study that I like to bring up, the ADHERE study, which is a patient registry that shows what patients reported that they liked about the device. So you can see here, 92% of patients said the Inspire device was better than CPAP. 92% of people said they would choose Inspire again. 94% of patients said that they would recommend it to other people, which is my favorite statistic. If you recommend it to someone, then you must really like the device and speak highly of it. It's worked well for you. 91% of patients said that they were satisfied with Inspire. So now I want to talk about patient eligibility a little bit. So the first eligibility criteria is that you're 18 years or older. I hope everyone here is over the age of 18. You also need to have a sleep study within about 2 years showing that you have moderate to severe sleep apnea. There is also a requirement that you fail CPAP. So I want to talk a little bit more about that because that tends to be where we get the most questions. What does inability to use CPAP look like? So we consider an inability to use CPAP is claustrophobia, you're taking the mask off in the middle of the night and you're not aware you're taking it off, you're unable to fall asleep with the mask on. That can look like inability to tolerate CPAP. For patients that use the device all night, every night, and are finding benefit of it, but they say, oh, I just really hate it, those people aren't the best candidates because we want to do the less invasive option if that works well for you, and then only do surgery if it's necessary. So only surgery for patients who cannot use CPAP. So if you're able to use CPAP every night, all night, I encourage you to continue to do so, especially if you're having a benefit from it. Lastly, there is a BMI requirement. So this one is insurance dependent. The cutoff is a BMI of 40, which BMI means body mass index. So basically your body weight relative to your height. Some insurances like Anthem or Blue Cross Blue Shield require your BMI to be under 32. Medicare requires your BMI to be under 35 in order to be eligible. And then lastly, we would do an airway exam like I talked about earlier. The final thing I want to talk about is troubleshooting. So another question that I get, especially with these community talks that I do, is a lot of patients will say, what if the Inspire device doesn't work for me? What do I do at that point? Does the device get taken out? Do we just say, okay, it didn't work for you, so sorry? And I wanted to bring up this list. So there are several different things that we can do to get the Inspire device to work. So if we get that sleep study back after 3 months and it's showing maybe it's treating your sleep apnea a little bit, but not as much as we want it to, these are all the different things that we can do. We can tweak the device, we can tweak the settings on it to get it to the point where it is treating your sleep apnea. You're feeling better, you're feeling more rested. So there are different things that we can do to work towards a successful outcome. Lastly, I want to throw this up here as well. I'm sure a lot of you may be wondering, okay, what do I do next based on my needs? So this is Dr. Nord and I, and then one of our sleep physicians, Dr. Michael Polsky, that we work closely with. So we as ENTs work closely with sleep medicine. So anytime patients, if you need a sleep test, if you need management for your CPAP, if you're not sure if you have sleep apnea and you want to get diagnosed, we'll have information in those little blue booklets that you were given for Dr. Polsky's office. He works with Pulmonary Associates of Richmond. So they do sleep apnea testing, CPAP management. If it's been a while since you've had a sleep study and you need a new one, that can be done through their facility. You can also ask your primary care doctor. They should be able to do a sleep apnea test for you or help you manage that. If you have tried CPAP and maybe it isn't working for you, and you've had a recent sleep test, maybe you're trying to use CPAP, but you're having that nasal obstruction that we talked about, Dr. Nord, you could visit Dr. Nord and I's office. We'll have our information in those folders as well. Otherwise, that concludes my presentation. These are my dogs. Any questions immediately? Yes.
Can you talk a little bit about the difference between CPAP and BiPAP?
Yeah. So.
Also, how you determine which is the best treatment, and also there's several different types of masks.
Mm-hmm. Yeah, so that's a great question. So she asked what the difference between CPAP and BiPAP is and how to know which masks are gonna work best for you. So definitely encourage you to visit your sleep medicine doctor. They will be able to, they can do mask fitting tests for you and try out you can do a full face mask, there's a partial face mask, there's one where it's just nasal pillows that sit underneath your nose. They have the hose coming out at different parts. There's a lot of different masks you can do. Your sleep medicine physician would be able to set you up with that. The difference between CPAP and BiPAP, so CPAP is continuous positive airway pressure, BiPAP is bi-level airway pressure, and it just refers to, again, CPAP is a continuous airway no matter what, and then BiPAP is giving you air at certain times during your sleep cycle. So when you take a breath in, it's sending air to you. And then when you exhale, it pauses. So it can be easier to tolerate for people if the issue you're having with CPAP is feeling like you're suffocating or feeling like there's just too much air going in my face at once. BiPAP can be a great option. Does that answer your question? Yeah.
There's 3 different kinds of sleep apnea. Can you talk about the percentage of people have obstructive versus central versus mixed?
Okay, yeah. So with obstructive sleep apnea, that is the most common type of sleep apnea. The percentage, I'm not exactly sure. I want to say it's about 90% of people diagnosed with sleep apnea have obstructive, which means there's something blocking the airway. Central sleep apnea is referring to you holding your breath at night. So again, obstructive, there's something in the way. Central is you holding your breath at night. And that can be caused by a lot of different things. That can be your brain not sending the signal to your body to take a breath in. A lot of people with heart failure or heart issues, maybe their heart isn't sending the right signals to their brain to say, hey, you need to take a breath. So those can be different. The mixed apneas, I'm a little less sure on. Again, that's more rare than obstructive, but is in the same category as the central sleep apneas. Any other questions? All right, well, awesome. Thank you so much for your time. We'll be in the back with Darlene if there are any other questions that you have. Thank you so much.